afternoon, everyone, and welcome to this webinar on understanding the impacts of cash transfers on health outcomes. My name is Amy Finkelstein. I'm a professor of economics at MIT and the co-scientific director of JPAL North America, and I'm going to be moderating today's webinar. Just a few quick logistical details. First, this webinar will be recorded and posted to our website in a few weeks. And second, please use the Q&A function to ask your questions. All right, so as you can see, we have a packed agenda today. So I'm just going to start very briefly by giving you a brief introduction or overview to JPAL North America and the motivation behind the webinar. For those of you who may not be familiar with our organization, JPAL stands for the Abdul Latif Jameel Poverty Action Lab, and JPAL North America is the North American regional office of JPAL. We're one of several regional offices around the world. We're a research center based in the Department of Economics at MIT, and our mission is to reduce poverty by ensuring that policy is informed by scientific evidence. And we basically take a three-pronged approach to advancing this mission. First, and what you'll hear most about today, is we fund and support research run by our network of over 800 researchers. And all of the projects you're going to hear about today were either funded and or given research support or an input by the JPAL North America network. Our second key area is policy outreach. JPAL supports researchers in synthesizing research results and sharing these results with policymakers to support decision-making. And our third key arm is capacity building, through which we provide training and resources to researchers, research staff, nonprofit, and government leaders to better equip them to evaluate, synthesize, and use rigorous evidence in their decision-making. Together, these three areas enable us to connect the dots from research to policy. And as I mentioned, the work we're showcasing today on cash transfers has so far focused on the first area, but part of the point of this discussion and the discussion among these three teams who have done different cash transfer RCTs is to start trying to synthesize what we're learning from across different studies to pull out both common themes and also understand what we can learn from the differences. The work today is focused on the impacts of these cash transfers on health, although of course these research teams and others are also looking at other impacts as well. All right, so as I said, today we're going to discuss three recent randomized evaluations of the effects of unconditional cash transfers on health. And these three transfer programs, as you'll hear a lot about in a moment, vary quite a bit in the population who was affected, the location, the dollar amount, the timing. We'll dive into some of the similarities and differences in both the setting and the results and try to unpack some insights into how policymakers can best use these results in their own context and how together these three sets of findings can help us build a more nuanced understanding of how cash transfers work. Let me just also flag before we get into the good stuff, and I promise I'll be quiet in a second and let the researchers actually talk about the research. I wanted to note that JPAL North America continues to be very interested in supporting randomized evaluations like these. If you're a researcher already in JPAL's network who has an idea for a randomized evaluation, we invite you to apply for funding in our next request for proposal window. If you want to learn more about the work we've supported and what else we're learning about cash transfers, please explore the landing page we've recently launched on our website about all things cash transfers. And so with that in mind, let's turn to the research. Our panelists, who will briefly introduce themselves, will share their findings and discuss the connections between them and the key takeaways from the evidence that policymakers can use in their own contexts. So to kick us off, Sumit, can you please start us off by briefly telling us who you are and introducing yourself?
Thanks, Amy. Hi, everyone, and thanks to JPAL and the organizers. I'm Sumit Agarwal. The research I'll be talking about today, I did as a PhD student at Harvard, and now I'm an assistant professor at the University of Michigan Medical School. My work is around examining the impacts of social and economic policies on health of lower income families.
Thank you. Lisa Janetian.
Thanks, Amy. Lisa Janetian. I'm a professor of public policy at Duke Sanford School of Public Policy. Most of my work has focused on children residing in low income and unstable resources at home. And I've done work on lots of RCTs, including welfare reform and moving to opportunity study. And I'm one of the PIs of the Baby's First Year study that you're going to hear about today.
Thanks, Lisa. Sarah Miller.
Hi, thanks for having me. My name's Sarah Miller, and I'm an economist at the University of Michigan at the Ross School of Business. A lot of my work looks at different means-tested transfer programs like the Medicaid program and SSI, and today I'm going to talk about the Open Research Unconditional Income Study.
And Kimberly Noble.
Great, thank you for having me. I'm a pediatrician and neuroscientist, and I'm a professor of neuroscience and education at Teachers College, Columbia University. I study socioeconomic disparities and how they relate to children's cognitive, emotional, and brain development. And I'm also one of the PIs of the Baby's First Year study that Lisa will be presenting on shortly.
All right, thank you all for your very pithy introductions, much appreciated. We're going to move into the presentations of each of the three studies being discussed. For those in the audience, if you have questions or comments about any of the individual studies, please put them in, please save them for the open Q&A portion. We'll kick things off with Sumit and the Chelsea Eats study.
Yeah, so we can go to the next slide. So the aim of this study was to understand the effect of an income support on healthcare utilization and health using a randomized controlled study of cash benefits in Chelsea, Massachusetts, which is pictured here and just north of Boston. Next slide. Specifically, we wanted to sort through two key pathways. In the first, more income could reduce financial stress and food insecurity, result in better mental health and overall well-being, and lead to less need for the use of healthcare. In the second pathway, more income might help pay for the time costs to take off work or transportation costs or copays, which improve access and lead to more use of healthcare. And so really the effect of more income on healthcare utilization could go either way. Next slide. Let me tell you about the cash transfer intervention and where it took place. You know, the city of Chelsea is a low-income community just north of Boston. It has a large Hispanic, Latino, and immigrant population. The city's residents were hit hard by the pandemic, by COVID itself, having one of the highest COVID-19 case rates in the state, and then also economically by the shutdowns and job loss. Next slide. To respond to the economic and public health crisis, the city decided to provide direct financial support to its residents so they could buy groceries or anything else they needed. And the city began accepting applications for debit cards worth up to $400 per month, which would be a large 20% boost to baseline income of around $1,500 per month. They began accepting applications in July 2020. And because they had more applications than they had funding, they decided to allocate the cash cards by lottery, which happened in September 2020. And then the cards were refilled monthly for 9 months from November 2020 through August 2021. Next slide. The eligibility criteria was just that you had to be a resident of the city of Chelsea and have a household income below 30% of the Boston area median income, which for a family of 3 was about $35,000. And then the city announced that applicants with children or those ineligible for other forms of federal assistance would have preference in the lottery, which they operationalized by giving families who met any of the criteria listed here additional lottery tickets, which we account for in our analysis. Next slide. So we do have survey results from Chelsea Eats that I'm happy to share more about in the Q&A, but I'm going to focus on the administrative records. You know, we assembled electronic health records from 3 major health systems in the Boston area: Cambridge Health Alliance, Mass General Brigham, and East Boston Neighborhood Health Center, and FQHC. You know, Boston is a pretty consolidated healthcare market, so together these 3 health systems account for 15 hospitals, 30 community health centers, and the many additional outpatient clinics in the area. And then we linked the participants to their medical records. So turning to the results, I'll first tell you a little bit about the participants. There are about 2,800 participants total, 2/3 allocated to to receive the cash transfer and 1/3 did not. There was good balance between treatment and control. 3/4 of the participants were female. Average age was around 45 years old. Mean annual income was around $16,000, $17,000. Reflecting the community, the Spanish as a preferred language was a preferred language for about 3/4 of participants, and 25% were diagnosed with depression or anxiety. And then the average family size was around 3 individuals, with most families having 1 or more children in them. So I have 4 main findings to share. First, in the control group, there are about 317 emergency department visits per 1,000 participants in the control group. That's the pink bar and to the left. And the cash benefit significantly decreased emergency department visits by 87 visits per 1,000, or a relative reduction of 27%. And it also decreased emergency department visits that led to a hospitalization. Second, the cash benefit significantly decreased emergency department visits related to behavioral health by 62%, and it nearly eliminated emergency department visits related to substance use disorder. Turning to outpatient care, there were about 4,300 outpatient visits per 1,000 participants in the control group, or about 4 per person over the 9 months. And the cash benefit increased outpatient visits by about 10%. And then breaking it down by specialty, there's not much going on in primary care. Access to primary care is actually pretty good in Chelsea. And then earlier I showed that behavioral health related emergency department visits declined. And then, the estimate for behavioral health in the outpatient setting is in the positive direction, but not statistically significant. And so any increase in outpatient visits is in visits to other specialties, which rose by 300 visits, or a 20% increase. And specialists can be hard to access from Chelsea since it requires you to block off several hours of your day and travel into downtown Boston. And then lastly, for urgent care, which can substitute for low acuity ED visits, increased slightly by 69 visits, also a 20% relative increase. And then finally, for the COVID-19 vaccine, we saw high vaccination rates in the control group of 84%, with no significant difference in the treatment group. The COVID-19 vaccine was released during this study, and vaccines were free, and there was a mass vaccination site right in Chelsea. So using a randomized study design, we set out to examine whether more income would lead to less or more use of healthcare, and what we found was evidence of both. Next slide. The first pathway appears to hold true for emergency care, where we found less ED visits for behavioral health and substance use disorder, perhaps because the extra cash meant less financial strain, less use of alcohol to cope, and more economic resilience. And the second pathway appeared to hold true for subspecialty care, as a cash benefit likely improved the ability of participants to pay the direct and indirect costs associated with accessing healthcare. And then perhaps there was a bit of substitution from the emergency room to outpatient care. But doesn't appear to be driving our results. Thanks, and looking forward to the Q&A.
Thank you very much, Sumit. That was terrific. Next, we're going to hear from Lisa Janentian on the baby's first year study. Lisa, I think you're still muted.
My apologies. Thank you, Amy. I'm delighted to talk about the baby's first year study today. I'm here with colleague and collaborator, Dr. Kimberly Noble. And I want to right away acknowledge that this is a large 7PI team. We've been working together for about 15 years on this study, and there are hundreds of other kind of collaborators, consultants, and staff. And we're grateful to JPAL for contributing to the funding of the study, along with many other partners in philanthropy. Next slide, please. I want to jump right into the design of the study, especially given that helpful context with the Chelsea Eats study. In this study, 1,000 mothers with low incomes were recruited in hospital maternity wards right after giving birth. We worked closely with 12 hospitals in 4 metro areas in New Orleans, Omaha, Twin Cities, and New York City. We did have some study inclusion criteria, being low income through self-report, a healthy singleton birth, and maternal proficiency in English or Spanish. And this is for reasons of measurement that we were going to do later on in data collection, and age of consent from the birthing parent. Families were first approached about their interest in a longitudinal child development study, and then they were asked about their interest to participate in the prospect of getting a cash gift. They were then randomized within sight into two groups. One we call the high cash gift group at $333 per month, which is about $4,000 a year, which is roughly a lump sum earned income tax credit refund amount for a family of two. Or a low cash gift group of $20 a month, $240 a year. We wanted to make sure to not confound the distribution of the money, the mechanism, from the amount of getting the money. The cash is automatically dispersed via debit card. It has little labels called "For My Baby." It is on the day of the child's birth. Families are receiving this cash gift for a total of 76 months. So think about 6 years in the first 6 years of a child's life. I want to quickly mention 3 other quick important things about this. We worked hard so that the money received through this study is not clawed back. The money is invariant to changes in family size and other aspects of the context over time. So it's the same money no matter what. And the money is coming from a private source. We've worked hard to stay in contact with our families with great success, and we've had good data completion rates. Next slide, please. So why did we spend so much time on launching a study like this? Baby's First Years is a study designed to fill a scientific gap. There's no evidence in the US on the impact of direct poverty reduction or poverty alleviation through these earliest years of children's development. This is indeed a time in which household income falls up to birth and immediately after birth. And this is co-timed with a period of rapid developmental growth. And so this team really represents a team of neuroscientists and social scientists with a real focus on trying to measure various aspects of early childhood growth. Next slide. We've had a really robust data collection going into the field every year over a 12-month period. The findings today are going to focus on what we're learning in the domains of health over this 4-year time period. Recognizing COVID happened, many things happened over this time period. I just want to note, and it's important for this audience, that families are still receiving the monthly cash gifts. In fact, we're in the field right now. The children are 6 years old, and many of the families are receiving their last cash gift payment right now. Next slide. So here is a map of the US to give some context of the families in the study. Here are the 4 sites. They vary quite a bit in child poverty. They vary quite a bit in cost of living and availability of services. The cost of eggs, it turns out, are much lower in Nebraska. I checked today versus the other sites as sort of a reminder of these contextual differences. So this is just to give some context for the variation underlying the sample. Next slide. A variety of data was collected at baseline. Indeed, the babies were healthy singleton births. They were about 7 pounds on average, a gestational age of 39 weeks. About 1/3 of the babies in this study were the firstborn child. Birthing mothers' average age at time of birth is 29. The far majority, 90%, report being in good or excellent health. It's a very racially and ethnically diverse sample, 40% Latina, 40% Black. Families on average report low income, which is about the poverty level for a family of 4, also very low wealth. The far majority of the families in the study were receiving some type of social assistance benefit when they entered the study, and 2/3 reported receiving Medicaid at the time of the BFY child's birth. Next slide. I'm going to next just kind of give an overview of 4 kind of domains of health that focus both on the mother and the child. So kicking this off with what we're learning about reproductive and physical health for the mothers. We're finding an increase in the use of short-term hormonal contraception, but otherwise we are not finding many impacts in uses of other contraceptive methods or satisfaction with contraception. We see a little bit of earlier timing on a subsequent birth after the BFY focal child birth, an increase in pregnancy, but no overall impact on fertility so far. We have found no impacts on breastfeeding that we collected in detail in the first year of life, and no impacts so far on mom's physical health, including sleep or BMI that was measured in person. Next slide. We have a very extensive battery collecting lots of measures of stress and psychological well-being focused on the mother. It's collected by survey in each of the years that I showed on that timeline. And so far, we are not seeing any improvements on reports of parenting stress, anxiety based on the general anxiety disorder scale, depressive symptoms, a scale that is designed to measure hope, nor on happiness or overall life satisfaction. Next slide. Now turning a lens to focal child health. We did find when the children were toddlers, mothers were reporting increased consumption of healthy foods, though no reduction in consumption of unhealthy foods. We find no impacts of maternal reports of children's health, sleep, or frequency of illness. We did collect focal children's BMI when they were age 4, and we do not see an impact there. Next slide. This study occurred over the context of COVID. I wanted to offer some statistics on what we've learned for this sample over this period. We have not found any differences on these outcomes, so these are descriptive characteristics of the sample. About 16% of the BFY families reported a COVID diagnosis for at least one household member. This was at or near the peak of the pandemic. During infancy, 50% of the mothers reported visiting a physician due to the infant's illness or injury, and 90% reported visiting emergency or urgent care. About 2/3 of the sample at birth report being on Medicaid, and that is pretty consistent year to year when we ask and collect that information. About 20% of the sample reported some medical debt. And just a note that I think is an important part of kind of our tracking and keeping track of these families, that not all of them are alive. 6 of the BFY mothers, and it's actually 7 BFY focal children, have since deceased. Next slide. So findings so far of this particular study is 4 years of monthly unconditional cash to families with low income and young children. We're finding the following. I did not present today, but we are finding that there is some increased household income. And we do find some increases in money and time investments, specifically in children, things like books and toys and reading time. But we are not finding so far improvements in maternal physical or psychological well-being or reproductive health. And so far, we're not finding impacts on focal child's health or access to healthcare or related early intervention services. Stay tuned. We are collecting a lot of data. We will have more information on stress physiology of children and mothers. And we're also continuing to collect data as the children transition into kindergarten. And we do have plans for a post-cash gift receipt follow-up when the children are age 8. Thank you.
Thank you. Thank you very much, Lisa. That was also terrific. Now for our last presentation, we're going to turn to Sarah Miller on the Open Research Unconditional Income Study.
Great, thank you so much. So I'm Sarah Miller, and I'm presenting these results, but this is a joint work with Beth Rhodes, Alex Bartik, David Brockman, Patrick Krause, and Ebba Vivault. Next slide. So this study looked at participants in 2 states, Texas and Illinois. We recruited 3,000 participants, and of these 3,000 participants, 1,000 were randomly selected to receive $1,000 per month, with the remaining 2,000 serving as the control group and receiving $50 per month. This transfer began in November of 2020. So like these other 2 studies sort of began during the pandemic era, and it continued for 3 years. The last payment was made in October of 2023. We recruited individuals who were ages 21 to 40 at the time we were recruiting them. So they ended up being about 25 to 44 at the end of the study and had self-reported household income that did not exceed 300% of the federal poverty level. Like the Baby's First Year study, we did put in some effort to make sure that this money was not clawed back. So These were unconditional gifts from nonprofit organizations, so they were not taxable. They also did not affect eligibility for benefits in Illinois and eligibility for some benefits in Texas. Next slide, please. So who are the participants in our study? About 37% of them have self-reported household income under 100% of the federal poverty level, with the rest having income between 100 and 300% of the federal poverty level at baseline. Their household income is a bit under $29,000 on average at baseline. Personal income is a bit under $20,000 on average at baseline. So this is really a very substantial gift relative to their baseline income. It's about a 40% increase relative to household income, or over a 60% increase relative to their personal individual income. 30% of the sample are non-Hispanic Black, 22% are Hispanic, and 46% are non-Hispanic white. On average, our average age is 30, and female participants are somewhat overrepresented, in part because of our eligibility criteria surrounding household income and the federal poverty level. About 67% of participants are female. So this is a relatively young study, a relatively young sample, but they do report at baseline having some noticeable health needs. So nearly 30% of them are uninsured, about another third are on Medicaid. More than a quarter of them report that at baseline that in the last 12 months, they had to skip some necessary medical care because it was too costly. About a third of them reported skipping some necessary dental care because it was costly. And despite having an average age of only 30, again, relatively young, about half of them are reporting that their health is not very good or excellent. Next slide. So this is, I guess, copying a little bit Sumit's slide. This is how we were thinking about our model of change for how income might affect health. We sort of thought of our outcomes in three broad buckets. First, as was described in the first presentation, if you need medical care but you can't afford it, or maybe you can't afford transportation, or you can't make the copay, income could directly increase your use of medical care, which could in turn improve your health. But even if you don't increase your use of medical care, there are other ways you might invest in your health that income might facilitate. For example, you might be able to afford healthier food, you might be able to take more time to exercise, get better sleep, etc. So there could be non-care health investments that you make as a result of income, which could in turn improve your health. And then thirdly, even if you don't get additional medical care, and even if you don't make additional non-healthcare investments, you might experience reduced stress, which could decrease inflammation in your body, and through a biological causal pathway, improve your physical health. So these were kind of the three broad categories we had in mind when looking at health. Next slide. So I'm going to describe our findings. Sort of, you can read all the details and all the individual outcome measures in the paper, which you can find on my website, but I'm going to describe our findings at a very high level for the purpose of this webinar. So first of all, we find some improvements in stress and mental health, as well as in food security, but they are short-lived. We basically only see significant effects, improvements on these measures in the first year of the study. So this figure that I've put here shows a standardized stress score that is based on a battery of 10 questions measuring different aspects of stress. In the first year, we find a significant, nearly 1/10 of a standard deviation decrease in stress in the treatment group relative to the control group. However, by year 2, the treatment group and the control group are reporting sort of the same amounts of stress as measured through this battery. And we find similar patterns for other measures of mental distress and, as I said, for food security. Next slide. The second finding is that we do find some evidence of that first arrow, which is that these income transfers are increasing the use of medical care. We find about a 10% increase in dental care, about a 10% increase in emergency department care, and about a 26% increase in hospitalizations. We also find some suggestive evidence that office or outpatient visits to specialists may have also increased by about 6%, and that primary care office visits could have also increased by about 8%. I have some asterisks next to those outcomes because those are only marginally significant and they're not statistically significant after we account for the fact that we're conducting a lot of tests. But taken together, I think these results suggest that providing people income could increase their use of medical care. Next slide. And then sort of the third big takeaway from this study is that we don't really observe much changes in anything other than those first two slides that I showed you. So we have a lot of different measures of physical and mental health. We have self-reported health on a 5-point scale. We ask about the number of days physical health was good. We ask about health limitations and experiences of pain. We collect measures of blood pressure, blood sugar, cholesterol, obesity, etc., we don't really find any statistically significant changes, and our confidence intervals are pretty narrow. We can rule out even very small improvements in these measures. We also look at that kind of middle bucket in the figure I put up of different ways you might invest in your health, like exercise, sleep, use of alcohol and drugs, nutrition, etc. And we, again, don't find much evidence that these intermediate measures of health investments have changed as a result of the transfer. Next slide. Great. So our takeaway then, going back to this initial model that we had, we don't find any evidence for the second set of arrows. So at least over the 3-year period that we study and the 3 years that the transfer occurred, we don't find any improvements in physical health. But we do find that income changes some of the intermediate steps that we might be looking for. In particular, providing people more income does appear to increase their use of medical care. And we find some evidence that it affects their stress, decreases their stress. It's just that this effect appears to be relatively short-lived. We don't find evidence for the middle arrow, which is that it changes their sort of non-healthcare health investments. Thank you.
All right, Sarah, again, thank you very much for that very clear and pithy summary. I know behind each of those presentations was an enormous amount of blood, sweat, toil, and tears, and many details that are available in the papers themselves. But now that we have a sort of basic overview of the 3 studies, I wanted to jump into a discussion about how to understand, synthesize, reconcile, choose your favorite verb, the results from the different studies, how they connect to each other, and to the broader evidence and policy questions surrounding cash transfers. And let me just say to the panelists, I have some pre-prepared questions, but that's mostly just, in my opinion, to make sure that we don't either sit in awkward silence or degenerate into chaos. What I'm really interested in is hearing from the 3 of you your thoughts and reactions about both what are the consistent themes that have emerged, and what are some of the key open questions that these studies have also raised. So feel free to, speak more broadly or bring up other things that I haven't mentioned. That being said, to start off, I just wanted to start by thinking about, what we mean by health and how we should think about the sort of many different dimensions of health that were looked at across and within these 3 studies. So everything from healthcare use, which was the focus of the Chelsea Eats study, but looked at in all of them, to different measures of physical and mental health. Do we think that Lisa and Kimberly on the baby's first year there?
Sure, I'm happy to address that first, Amy. Thank you. So it's interesting, right? Cash transfers really have the potential to affect a lot of the more distal experiences that really lay the foundation for good health. So, for example, they could enable families to afford more healthy food like fresh produce, which is, excuse me, in fact, something that we observed in our study that Lisa mentioned. They alternatively could enable families to afford higher quality housing without exposure to environmental toxicants like lead, or without pests that increase the risk of asthma. They could enable families to live in safer neighborhoods, or neighborhoods with more green spaces that promote physical activity. And of course, it's possible that cash transfers could reduce stress, which is tied to a host of health processes. Although, of course, the evidence is mixed even among our own studies as to the effect of cash transfers on stress. So I think, looking at some of those distal mechanistic processes for how cash transfers can affect the pathways that lead to health will be very informative.
So just to, I think, maybe just echo back what you're saying, I didn't do any of these studies, but had I been thinking about them, I would have started by thinking to myself as a health economist, the most natural channel being the healthcare use channel. And your point is, of course, that's one mechanism through which we can improve health, but there are many, many others that, that income can affect that have nothing to do with medical care, be it the environment in which you live, the housing. Yeah. So
healthcare access and healthcare utilization is, of course, important, and we can imagine lots of ways that cash transfers could affect that. But as a physician, I think in terms of sort of the mechanistic pathway between what resources we have, what money can buy, and how that leads to greater health. So again, things like access to fresh foods or the ability to purchase fresh produce and afford less calorie dense but more healthful choices for children and families. Is one potential mechanism.
I wanted to ask Sumit or Sarah if they wanted to sort of talk at all about this broader question. Yes is great, no is also fine.
Yeah, I can jump in. So, I think we all agree health is a multi-dimensional concept, and our studies capture various facets of it. So in addition to being a researcher, I'm also a primary care physician. And so, the ultimate outcome, a health outcome, is mortality, right? That we frequently assess in the medical setting. And it's relatively easy to measure, but it's rarer and it's harder to move, especially for such a non-specific intervention like a cash transfer, where I think cash transfers have more potential to move a health outcome is something like mental health, right? And I think all three of our studies assess mental health in some way. And there's growing, evidence that financial insecurity contributes to poor mental health. And so perhaps relieving financial insecurity can improve mental health, in which in Chelsea, we saw the reduction in emergency department visits related to behavioral health. And then, of course, there are validated survey questions to get at mental health too.
Sorry, Sumit, I apologize if I missed it. What did you find on the survey results on mental health?
Yeah, so about 2/3 of the Chelsea participants were surveyed, and they were asked the generalized anxiety questionnaire, the GAD-2, and the PHQ-2 for depression. And there was actually no significant effect on either of those measures on mental health, even though I'm telling you that my results using the administrative records found a significant improvement in emergency department visits related to behavioral health. And so, I've thought a lot about how to reconcile the survey results with the administrative records. And it turns out to be primarily driven by the fact that 2/3 of the participants participated in the survey. And if you do the administrative records results by survey participation status, the result of the reduction in emergency department visits for behavioral health are entirely driven by those who didn't opt to participate in the survey. So that,
Which
raises questions about who we reach with our surveys and, what bandwidth they have to respond to surveys. And then, even beyond survey response rate, who we recruit into our studies in the first place.
No, and it also points out a huge advantage of administrative data. Not only is it less expensive to collect, and also can have much more detailed information than you can gather in a retrospective survey, but you do get the universe. Of course, it's only as good as what it can measure. So those are, clear trade-offs. Speaking about reconciling results, that was really interesting in terms of within your study on the two measures. I also wanted to engage you and Sarah a little on, what your thoughts are of the fact that of what I would say are ostensibly conflicting results. That your Chelsea Eats study finds that cash transfers decreased use of the emergency department, while the open research study found that it increased ER use. And just hear from each of you of your thoughts about what we learned from that.
Sarah, you want to go first?
Yeah, sure thing. Yeah, I'm happy to kick it off. So first of all, I would say I think we often think of going to the emergency department as this bad thing that we're trying to avoid. We have, one state in our study that adopted the ACA Medicaid expansions and one state that didn't. So we have some pretty meaningful representation among people who are uninsured or maybe have high out-of-pocket costs of care. And so I think we don't necessarily view the fact that they're using more emergency department care as like a bad thing. I think there are also a few other differences between the studies that is important. And I actually think this is a theme throughout understanding these studies, is the potential for real heterogeneity in the response to getting a cash transfer, especially because cash is so, like Sumit said, non-specific. I mean, I think it was interesting what Sumit just said, that even within their sample, which is a little different, it's older, it's a little bit lower income. It was, during the pandemic where there was a really big spike in substance use disorder deaths. only a third of their participants were actually experiencing this decline, if I understood you, Sumit, in use of the emergency department, right? So I think that even goes to show that even within the Chelsea Eats study, there's a lot of heterogeneity in what's going on, right? Like, it's not like everyone in Chelsea Eats experienced this decline. And so I think, we have a relatively younger age group, average age of 30. I think that could be playing into it. And I think there could be just enough difference in context that is what's, part of what's going on. So I think I'd love to, get together sometime and dig into it more, but I think that's kind of my takeaway. Sumit, what do you think?
Yeah, I completely agree with that. I think, the first kind of layer is it has to be differences about the study population, or it has to be differences about where it took place. So Sarah had mentioned a couple of those. Chelsea Eats was a little bit older, and it took place right outside of Boston, whereas Open Research was a little bit less poor, less old, and then took place in Illinois and Texas. And so thinking about those differences and what that means for emergency department utilization, in both of our diagrams, we pointed out that more emergency department use could mean better access, and less emergency department use could be more health. In Chelsea, access isn't an issue. To the emergency department, access isn't an issue, right? Like, there's so many emergency departments right near Chelsea. I would venture to say that our insured rate is higher than what it was in Open Research Unconditional Income Study. So if anything, if income was going to do anything to emergency department use, it wasn't going to improve access. It was just going to improve health. And that's what we saw, the improvement in health that led to a reduction in the emergency department utilization.
Related question, Sumit, did I understand correctly that most of the decline in emergency room use in Chelsea Eats came from reductions in behavioral health and substance use ER visits?
Yeah, it's kind of across the board. If you look at the diagnoses and use the Billings algorithm, but it's like the largest relative change in behavioral health diagnoses, which includes like
And
depression, anxiety,
especially,
suicidal ideation.
yeah, so I guess my question then is the sort of baseline rate of substance abuse and or behavioral health issues, whether you measure it in baseline administrative data or in a survey, very different between your two studies? Do you guys happen to know?
Yeah, I don't think, when I recall looking back at Sarah's study, I don't remember them being all that different. I mean, ED use is around 400 per 1,000 participants, and I don't think Sarah's was all that different from that rate.
Interesting. Yeah, so let me ask the question a little bit more pointed, and it's totally fair if you don't know, but imagine you were, given a large grant with the goal of trying to understand under what conditions, unconditional cash transfers are more likely to increase versus decrease ER use. But you can only have like 2 or 3 arms. Like you don't have it. It's a large grant, but it's not an infinite grant. What are your sort of favorite hypotheses that you would want to see tested or studied further? Either of you.
Well, I would, maybe it's too simple of a hypothesis given what we know, but I think, the fact that it's one difference is the insurance coverage, and a second big difference that jumped out to me was the age. I think those would be the two, if I were to generate a hypothesis about what's driving the differences, that would be those two factors that I think are important. And I think I could do a good job. So if there's anyone on this webinar that has a huge grant that they want to give me to study this, I think you can find my contact information on the webinar homepage.
Excellent. Thank you very much. Sumit, did you have anything you wanted to add besides insurance and age?
No, those would be the big ones. Yeah,
Guess
just
you'll-
more places where there's variation in insurance status or availability of safety net services.
I guess you'll have to split
Yeah.
the grant then.
Hey, Amy, do you mind if I add
Oh,
to
please,
Kim's
please,
last
yeah.
point? Yeah, and then Kim, I guess you have something to add as well. I mean, this is really interesting, right? Because with our study of babies' first years, I mean, they were healthy births, so let's put that aside in terms of the kiddos. But there's high attachment to the safety net, right? Because these are families with young children. And so they've got most of them have Medicaid. So it's interesting thinking about your question, Amy, and I would think about the variations of Medicaid access across sites, right? And the quality of services that are Medicaid covered. And how does that interact with, all the stuff that happens when you have a little kiddo, right? Are they going to the emergency room for asthma, or do they have a pediatrician set up in a medical home that the cash can help? So that's kind of where my head was going. Kim, do you have other things to add?
Well, I was thinking about this question of age actually, and I don't know if we said it, but right, so we did not see differences in healthcare utilization for the kiddos, but these were, as Lisa just mentioned, kids, healthy births, right? These were kids by design, born in the well baby nursery. So at age 3, when we measured healthcare utilization, we wouldn't have expected a whole lot of, major illness among these children. And we didn't see differences in healthcare utilization either in terms of preventative care or ED use. What I wish we had measured following the other 2 presentations was ED use or healthcare utilization of the moms, which unfortunately we don't know. So I think it's an open question, but I could certainly imagine a hypothesis where you would begin to see differences in healthcare utilization among an older population that's going to have more healthcare issues.
I would probably throw one more thing in if sorry.
Go for it. Yeah, no, please go for it.
Yeah, I think another thing is the timing. Again, thinking of Chelsea Eats and the ORIS study, a lot of our year 1 results look more like what they found in Chelsea Eats, right? So for example, Chelsea Eats found a reduction in food insecurity that was statistically significant. Sumit, again, I'm remembering, if I remember wrong, correct me, please. And we found something very similar in the first year, and then we've had this fade out effect, right? And so I think there also could be sort of differences over the efficacy of like a short-term transfer that's like, you're getting this for 1 year, maybe don't go out and buy a new car and move to a new place, but like this is kind of like a short-term relief versus like something that's a little bit more long-term. So sorry, I forgot to mention that. I just wanted to throw that out there.
Can I add, sorry, this is becoming now, I have another thought around that. That's interesting, Sarah and Sumit, because it's getting me thinking about the lump sum transfers around birth and a variety of other types of studies where you're seeing a little more movement on the kinds of outcomes you're talking about. So I think that's a really good point, one time or a limited time burst of resources and how that might be used, compared to something like we designed in baby's first year is modest monthly for a really long time.
So needless to say, you guys have managed to generate wonderful ideas for hopefully that generous funder in the audience to sponsor more RCTs on that. And of course, we'd love to help if we can. Can I ask though, and I know this is no substitute for, such an RCT, but maybe as a complement of the 3 things I heard, age, insurance coverage / access, and, fade out effects. Is there stuff, I mean, obviously the more you cut the data, the more you run into power issues, but I'm wondering, Sarah, is there a way to look at a subsample that looks more like in age, the Chelsea Eats population, or split by insurance coverage, whether that's the cross-state variation or even with insight? And, Sumit, just, to pile more work on you, following up on what Sarah said, I wondered, it might be interesting to look at the effects after the transfers end on emergency room use. And then not to let Lisa and Kim go unscathed. Kim, you said you were sorry now that you hadn't collected emergency room use on the moms. The beauty of administrative data is it's still there. So maybe that's something you could go back and do, or if you're still in the field, ask them about it, although there's always recall issues.
Lisa and I literally texted about looking at this in administrative data as the presentations were going. So
wow, that's amazing. That's terrific. I wanted to. Oh, please go ahead.
Oh, sorry, but did you want us to respond to that or?
Oh, sure. Yeah.
I would just say that we looked at a lot of, so we're kind of limited on age heterogeneity because we have age cutoffs, but I would say the thing that jumped out as the group that seemed to benefit the most on the health dimension was the group that reported at baseline that they needed medical care that they couldn't afford. That was really the only group where we saw significant improvements in self-reported access and actually positive point estimates on like physical health and mental health, although they were pretty noisy. So I think that kind of actually speaks to one issue with cash, which is that like there might be some group that really wants it to improve their health, and there's another group that wants it to invest in their kids, and another group wants to take a vacation, and another group needs a new car. And so there could be a lot of this heterogeneity that we've been talking about. On average, you might not see an effect when averaging over all these groups.
I'll add one dimension I've been thinking a lot about in a way to reconcile all our results is the experience of a negative income shock. You know, this is picking back off of what Sarah was saying, that our results in the first year look very alike. And that's because a lot of people are experiencing a negative income shock, whether it be job loss or illness. Is there a way that we could predict who is likely to face a negative income shock, or who is experiencing a negative income shock, where this like sudden infusion of a monthly cash transfer would have the biggest bang for its buck, and we would actually see effects?
I mean, that gets into very interesting questions about sort of optimal targeting of cash transfers. So even leaving aside potential incentive issues, where if you get cash transfers, if you lose your job, or have a negative income shock, that could, just as a pure, leaving the incentives aside, do any of you, looking at your own work, looking at the rest of these studies, looking at the larger body of literature, have a sense that if your only goal were to, and I'm not saying it is or should be, but if your only goal was to maximize the impact of the cash transfer on health, what population you would target, be that age, insurance coverage, part of the country, changes in income, as Sumit just said. I'm just trying to get a sense of, what, if anything, you think we've learned about targeting if the goal is to improve health. And of course, cash transfers have many other goals besides that.
I mean, I think the other two studies are probably a little bit in a better place to speak to that broader question, Amy, because our study was just so narrowly focused on, birth of the child. And as we've already discussed, lots of attachment to Medicaid and other safety net benefits and healthy kiddos. And so I think of the cash in this context as like getting out of some impossible choices, right? So maybe it's not this impossible choice between, paying for rent and having food on the table. Or maybe it's not the impossible choice of, do I make sure I have a working car that I can now go to the grocery store and get some healthy food, or, take 3 or 4 hours for other modes of transportation. I think it's harder for me, at least, to think about how your question about of our study of families with young children in the US and in this context of what is the health outcome I would expect to move in response to cash.
So let me just follow up on that before then I turn it over to Sarah and Sumit to discuss the targeting question, which is, Lisa, tell me if any of this, is a reasonable interpretation, because I don't work in the field of child development at all, or Kim as well, please, which is my sort of vague high level, or I guess more accurately, low level understanding, is that, there was a lot of thinking around the critical time period of ages 0 to 3, how important that was for child development. And, one could therefore imagine, I don't know what your conversations were when you were starting the study, that really could have been, getting more resources. And as Kimberly was saying, this isn't just about medical care, but holistically more resources could actually, have a major impact on the long run development of children, their health, their psychosocial well-being. I guess relative to that hypothesis and relative to the results you have so far in the first 5 years, would you say that we should update negatively on that hypothesis? But do you think there's still major things we might find at age 12? I'm just trying to think about, again, maybe my understanding of the landscape was wrong as well, but so you can speak to either that and or my interpretation of what you found.
I mean to take yes.
Yeah, go ahead, Ken.
So, yes, so you're right, Amy. Baby's First Years was really designed to primarily measure the impact of unconditional cash transfers on child development in the early years of life, right? So we have some health outcomes because we recognized it was important to measure that, but it was never intended to be sort of the primary set of outcomes of interest. And to answer your other question, it would not be, young, healthy births that I would choose if you were designing a cash transfer study to measure the impacts of health. That said, in terms of health, right, again, we know that many of the foundations for lifelong health are laid in early childhood. And so if we are fortunate enough to be able to follow these families for many decades, I do think it's plausible that an infusion of early life resources could lead to a number of cascading mechanisms that could result in improved health down the road. But I think until these kids are old enough to develop more health problems, things like metabolic syndrome, type 2 diabetes, right, even mental health issues as they get older, right, one would expect it to be difficult to detect early in childhood. In terms of, I think what you were asking, are we seeing impacts on child development? Is that sort of what?
Yes, yeah.
So it's a complicated picture. We've got some preprints up. Obviously, that's not what we focused on today. What we have seen in sort of high level summary is some early impacts on brain activity in the direction we expected, some more recent impacts on brain activity that are a bit more complex and require a little bit more thought to sort of interpret. We're not seeing early evidence of impacts on cognition and behavior at the preschool age. We've got lots of thoughts as to why that might be, recalling that, 2.5 or so of these children's first 4 years of life coincided with the pandemic. And we are currently in the process of measuring impacts of 6 years of monthly unconditional cash on 6-year-old child development. So I think we'll have a clearer picture of the effects of any impacts when the current wave of data collection is complete.
Thank you for reminding us of those results, and also the broader point, which I even said at the beginning, and then myself, of course, forgot, as one gets sucked into the health results, which is, there are many ways that cash transfers can improve well-being that are not through the health channel. But to get back to health, let me turn the question that I incorrectly posed to the two of you onto Sarah and Sumit about sort of, what do you think you take away about if you had a fixed budget and the goal was to improve health, where these programs might be best targeted?
Yeah, I think one answer to the question of optimal targeting for health is, older population that maybe has, financial insecurity or mental illness. But there are two things I worry about that kind of targeting. The one worry is that, if your health is so poor, it's not cash that you need, right? You need healthcare at that point. And so that might be a better way to target your resources, is in healthcare, not in a cash transfer. But then so that's one caveat, is you need to find this sort of sweet spot where the health isn't so poor that it isn't cash that they would benefit from. And then the sort of the second caveat is, this goes back to how the results are concentrated among the survey non-participants, is the survey participants and non-participants kind of look kind of similar on observables. There's some slight differences, and they're older, more disabled, lower income. But I think if we just use our observable characteristics, we might actually capture the population that we're most interested in. Like, for example, the Chelsea Eats participants were recruited off a food pantry line. Like, that's sort of a, an out-of-box way of thinking about who we recruit into our studies, or who gets eligible for our programs, that stands to benefit most from them, which is what we ended up seeing in Chelsea Eats.
Yeah, I guess I feel like I need to represent a little bit the voice of pessimism. I mean, I think it seems like we now have a lot of evidence looking at really substantial cash transfers. Baby's First Years is great. My study, but there's also like Compton Pledge. There was a huge cash transfer study in LA. They're not, except for Chelsea Eats, they're not finding improvements in health. And these are really, really costly interventions. These are like enormously, the open research study, that's $36,000 per participant, right? We know from other RCTs that if you want to make people use more medical care or use more outpatient care or have lower stress, like your work from the Oregon Health Insurance Experiment, that's increased medical care far more than what the open research study did at a fraction of the cost. There's also been RCTs about helping people make appointments to primary care physicians that have found really good outcomes. There's been work showing, like there's the IRS, RCT showing, like nudging people to take up insurance. Very, very low cost interventions that have way more bang for buck than cash. So I'm open to having my mind changed if we get new results, but I think also we should embrace what we're seeing so far. If we think these studies are good, and I think they are, that cash can do a lot of really great things. It can decrease consumption inequality. It can do a lot of stuff. But if what you really want is lower blood pressure, or you really want more primary care physician visits, it's hard for me to look at this and say, yeah, this is the solution. We just got to find the right targeting. I think that's really not realistic.
That's super helpful. Do any of you want to agree or disagree or nuance that
have an interesting nuance. I mean, I'm curious to engage with Sarah and Sumit on this, which is, I'm just reflecting on the moving to opportunity study. Right, so that was not an individual resource infusion. That was, I think of it as, it was a housing voucher, but the meat of the study in terms of what we're understanding is a change in place, right, in the quality of the neighborhoods. And there the most striking impacts were, right, on health and physical health and mental health. And so it really has me thinking about, what is this combination of resources to families and quality of place? And when we combine the information we learn from these studies, what we're learning about neighborhood poverty, does that get us to a different set of questions about health outcomes? So I don't know if either of you thought about that, or even if you have neighborhood level variation to think about. You didn't mention if there's mobility or moves into different housing quality in your studies. I can't recall if you've measured that.
I love that comparison to MTO. I'm such a huge fan of all of your work, but I mean, I think one thing that makes me think of is that these cash transfers are such individualized interventions, right? Whereas MTO, it was like you're changing the whole setting, you're changing the whole milieu where this is occurring. And I actually talk about in my class this kind of contrast between, MTO wasn't really set up to be a health intervention, and yet one of the most pronounced effects for the adults, at least, was the health paper. So I think that's interesting. We do find that people use the transfer to move. And again, I don't want to be like super negative. Yeah, maybe these moves are going to in the future result in health improvements, or there's going to be other changes to be found. I'm just saying, like, given the evidence I've seen, I've definitely updated downward. But absolutely, and I mean, I think it's great to bring up MTO, because again, we're treating like one family, one person, right? We're not treating their whole community.
It is really interesting, Lisa, because I look at the cash transfer discussion, and despite hosting this webinar, I feel it's important that we all keep reminding ourselves that cash transfers can do many things, even if they don't improve health. And then I look at MTO, where the top of mind for me, and I would suspect a lot of other people, was not health outcomes, but economic outcomes, or, educational outcomes. And then you find the health outcomes. So I guess in some sense, it's an important reminder that benefits can come in many forms, not all of which are obvious ex ante, and sort of a reminder that if you are doing an intervention, whether it's a housing moving intervention or an unconditional cash transfer or a health insurance intervention, the broader the set of outcomes you can learn about, the more, I guess, we can update our priors. I can't resist asking, this is so out of scope because I don't think any of you have any within study variation on this, but one thing I was struck by, which was kind of obvious, but I hadn't really thought about it, looking at the Chelsea Eats visual card that Sumit put up, and looking at the baby's first year, card that you put up. These are what I think we would call labeled cash, sort of cueing you towards food or towards children, as opposed to the open research study, which I think was fairly just unlabeled cash. I don't know if it was marketed in some way that, and so I'm guessing none of you had an arm that had an unlabeled version. And I'm not sure if any of you were able to, how detailed the consumption you were able to look at, but do you have any thoughts or expectations? There's a lot of literature in other contexts that labeling the cash affects how it's spent. And therefore Chelsea Eats might have more of an impact on food consumption, and Baby's First Year might have more of an impact per dollar on children. But I don't know if you have any thoughts or evidence to speak to that.
You want to go first?
Yeah, sure. So yeah, I think labeling definitely matters. We do see where the money was spent from the debit cards, and maybe like 2/3 or 75% was spent at establishments where food is the primary product. So unsurprisingly, it's called Chelsea Eats. It was meant to address food insecurity. Um, yeah, I was gonna say something else about labeling. I'll come back to it. I'll let one of you go.
Okay, can't disagree. The card was it was labeled, and it's like even more than that, right? This whole endeavor that we're engaged in is very focused on the child. It's child development study. It's at birth of the child. The money is dispersed on the date of that focal child. And so indeed, there is potentially lots of kind of mental cues and ways that we're reinforcing how to think about children and spending on children. And we do indeed see, right, increased expenditures on child-specific goods. We do see some other types of things moving, like food, but not in the way and not as consistent as child-specific expenditures.
Very interesting. I
Yeah.
guess my last question before turning it over to the audience questions is, I mentioned at the beginning that the key mission of JPL North America is not only to support and encourage rigorous research on important policy issues like you all are doing, but then ultimately to try to translate that into how we should be thinking about policy and actually making policy decisions. I realize we're still, with this latest round of cash transfers, fairly early in that journey. And our conversation has ranged over a wide range of topics, including understanding results within studies, across studies not covered here, what are the outcomes one should be looking at. So with all those caveats in mind, if the generous grant funder in our audience is replaced by the curious and intellectually engaged policymaker, what thing or things would each study team want them to take away if they're considering doing a cash transfer? And that I leave that deliberately open-ended because I think there are many ways one could take that question, and I'm just interested to hear from all of you about that.
For me, I think the two most important potential takeaways are, one, the importance of targeting for the reasons we've already talked about, and then also just harnessing administrative data to look at outcomes. I think those are the two kind of main takeaways I took away from Chelsea Eats.
Thanks, Sumit.
I mean, I guess I would
So-
maybe just reiterate a little bit what I said earlier, which is that if you're looking for a very specific outcome to move, cash might not be the right tool for the job. If what you want to do is give people the flexibility to spend it on whatever consumption is giving them the, not to sound too much like an economist, but like the highest marginal utility of consumption per dollar, then that's a really great option. But I feel like a little bit the discussion around cash transfers has been a little unrealistic before the results of these studies had come in, and almost given people the sense that you give people $1,000 a month and all of their problems will be gone forever. And so I guess I would encourage policymakers to look at these studies and to have realistic expectations about what such a cash transfer can do. I think expecting it to improve health and make them more productive in the labor market and make them get a college degree and all their kids are, but I mean, it's just, there was a ton of hype about cash transfers, and I think it needs to be brought back down to earth. Not that cash transfers are bad, but like if you go in expecting the world, then you're going to be disappointed and there's going to be backlash. And so I think that needs to be communicated.
Building off of that, I guess I would say I think it is important, and in some ways this is more for our job as scientists before we translate to policymakers. But I think it's very important, again, to sort of think about the mechanisms and the sort of causal pathways that take us from cash to the outcomes that we're interested in. by design, there's going to be heterogeneity there, right? Because different families are going to use the cash differently. And so I think if there's a particular outcome we're interested in, we're going to need to sort of follow the causal pathway, whether it's uh, healthy produce consumption leading to long-term changes in diet and health related outcomes, or differences in amount of time we spend reading with kids, which may have cascading effects on development, right? I think we have to sort of trace those causal pathways and then think about how do we emphasize or promote a particular pathway that we're interested in.
Do I have time to chime in?
Absolutely.
Okay, cool. I'm gonna build on some of the really awesome feedback and thoughts so far. So my head goes in two directions. One is thinking about this monthly lump sum kind of distribution of resources, and maybe there's room for both. So you can do specific things with lump sum, big change maybe that's not necessarily possible with monthly. You can do different types of things with monthly. And so I think that's an interesting question of how do we think about timing of infusion of resources, and also over the course of children's development. And then the second thing is, I really like what Sarah said about, cash is not going to solve all the problems and all the challenges of families and people who are already working really hard to get by. And so how do we think about cash plus, right? How do we think about mental health interventions along with cash? Because I think I would also argue childcare, early education, early information, that's also a hard thing to think about without cash resources, right? To be able to have the time to read, have the bandwidth to deliver. And so, some combination of cash and care models, which is showing a little bit of promise, not in the US context, but have been tested in other contexts.
I've been told I should go to the audience questions, so I will, but I just can't resist just commenting briefly, just channeling what Sarah said, because I am also an economist. My instinct of you give people cash and they're going to do whatever is best for them, and that may or may not be about their health in the short run or even the long run. With Kimberly's comment about multiple pathways, in some sense, they're very related, that if we think what people do with their cash is whatever is going to be best for them or their family, for some people that might be investing in their health or things that also produce health, and for others it might not be. And so it's actually completely consistent that there are people for whom cash would improve health and people for whom they would choose to do other things with their cash, either because their baseline health was, sufficiently good, or because they had more pressing needs. So I think it's definitely gotten me thinking more about these issues. But now to turn to some of the audience questions, because we only have about 15 or 12 minutes left. A bunch of questions came in, and I may or may not have time to get to all of them, but I will do my best. Just to start with one question that said, if some of these studies found no impact on actual health measures, how should we reconcile that with the hypothesis that financial security should improve health? Do we think that that link is no longer valid? Do we think that these didn't meaningfully impact financial security? Discuss.
Well, again, I'll say for babies' first years, right, our health outcomes are really centered on young children. And so I think the jury is still really out as to whether, increasing economic resources early in childhood will lay the foundation for subsequent health, right? We just don't know.
Yeah, I would say for the ORIS study, some of our financial security outcomes, not all of them, I won't try to detail everything, look a bit like the stress score that I showed you, where we see the improvement in the first year, but it's just not durable. And so I think we do see improvements in the first year. We do see potentially improved financial outcomes. Again, not every single I'd encourage you to look at the papers if you want the details, but I think there could be that link, and perhaps it's just the cash is most effective on a shorter term intervention, or it's most effective the first year you receive it, and then you kind of get used to having this cash every month, and it's less effective at improving the financial piece, and then it's less effective at improving health potentially.
I'll add that I still think the link is valid between financial security and health. I mean, unbiased because I did find that in Chelsea Eats, for example, but maybe if you pair it with like financial security plus and negative income shock, that's where the link is strongest. And the second thing I'll say is about the measure of mental health. You know, we tend to use these survey measures like the PHQ-2, PHQ-9, GAD-7, GAD-2, a overall marker of like how many days in the past 30 have you been in poor mental health. And we call those mental health, but you know, how accurately are we capturing the experience of mental health? You know, in the clinic, the PHQ-9, like the most important question is none of those 9 questions of the PHQ-9. It's the last question that's not even in the score. It's how does this mental health impact your functioning on a day-to-day basis? And that's not part of the score at all. And I've tended to see a lot of interventions start to use PHQ-2 and GAD-2, and these 2 subscales weren't designed to track mental health over time. I mean, your mental health on a PHQ-2 on a PHQ-9 could go from like 30 to 25 or 30 to 20, and you'd still max out the score on a PHQ-2. So I caution people to use like a PHQ-2 or a GAD-2 when they're trying to measure mental health.
Thank you. It's all very thought-provoking. I'm going to turn to the next question, which was it's probably more related to the open research and the Chelsea Eats study that were more short term, but it of course pertains to baby's first year, even though 6 years is about as long as I've ever heard of an intervention going. And this is a question near and dear to my heart because we got the same question when we did work on, the impacts of covering low-income adults with health insurance for a year or two. And the question is, I'm not questioning the evidence here, but I'm curious about the implications, given that the message from advocates of cash transfers is often that the intervention must be sustained over time to allow people to make plans and to change their lives in sustainable and longer term ways, right? And we all know, like, yes, of course, if we could do a long study and, live to see the results, we would. But what would you say to, I guess, an advocate whose response was, yes, cash can be transformative, but you have to have it know that you're going to have it for 40 years. Would you say, well, okay, we have nothing to say about that, or we have some indications that can speak to that?
I feel like I've kind of played the role as a pessimist, and I am happy to continue with that. Of course, we only have the intervention that we had. It was 3 years. Maybe if we had done it for 20 years, it would be different. But I think some of the time patterns that we've seen have made me kind of pessimistic that if we had doubled the length or tripled the length of time of the intervention, that we all of a sudden these amazing results would emerge that we're just missing out on. I mean, I think the fact that even only halfway through the transfer period, we see the improvements in food security kind of go away. We see the improvement in stress go away. Makes me more pessimistic that if it had been a 5-year intervention, it would have generated really, really durable results. So I guess that's, of course, we won't know until I get that call from that funder that's on this webinar to do the 20-year intervention. But I think it makes me pessimistic. I'd also point out that there is, cash transfers in the US do tend to be time limited, like TANF is time limited. The refundable child tax credit wasn't permanent. A lot of times when we do cash transfers, we don't say, we're going to give you this unconditionally for the rest of your life. There are some settings where we do that, like when people are permanently disabled. But I think realistically, I don't know that we would find better results with longer transfers. And if anything, I now feel like we would find better results with shorter transfers, but given to more people if we fix the budget.
Let me follow up on that, Sarah. Maybe I'll beat you on the pessimism front. And apologies if you already said this and I just didn't hear it. But what is your interpretation of the fade out effects of the sort of positive first year results? And is it sort of related to something Sumit said, that actually what matters is a change relative to baseline, in which case, if we're on the sort of hedonic happiness treadmill, then in fact, maybe that's why short-term, injections can be better? Or did you have a different interpretation to the fade out?
Yeah, I think we were, or at least I'll speak for myself, not my co-authors. I mean, I sort of think of 2 possible reasons. One is the hedonic treadmill idea. You get more cash. Initially, you're excited, you feel really great, but then eventually you kind of get used to the fact that this is your income and you no longer kind of feel that subjective benefit. And I think that's something that has been found in other analysis, like in the HRS, if you see a spouse dies, people are very sad at first, but people kind of go back to their baseline happiness or sadness after a period of adjustment for a lot of different shocks. I think the second hypothesis is we do see a lot of people in our study engaging in what I would call longer term consumption contracts, moving to a new place, signing a lease that has higher rent, buying a new car. Now you have a monthly car payment. And so you might be consuming more technically, but at the end of the month, you might feel just as liquidity constrained once you kind of make all these commitments as you did before you started getting the transfer. So I think both of those things might be at play here.
Sumit, did you want to weigh in on the, what if we had done Chelsea Eats for 25 years? Do you think we've learned something from the first 9 months that would carry over to that?
Yeah, I had a couple thoughts here. So earlier you'd asked me, do the effects last past the end of the cash transfer? And maybe that's a little bit relevant here. So the point estimate is nearly the same, but then the confidence interval crosses 0, so not statistically significant anymore over the next following year. I do agree that advocates tend to say if you raise the amount that's transferred, or if you extend the length that is transferred, you'll see the effects that you didn't see in the original program. And I do think that's probably not the right approach. I still do think it's about targeting, finding people who are likely to experience a negative income shock. So the analogy I think about as a physician is, when a patient gets admitted to the hospital, for example, for heart failure, I'm never able to make them quite whole again when I discharge them. And, in fact, they may never be quite whole for the rest of their life. And then there's a series of hospitalizations that sort of knock you down on your health with each subsequent hospitalization. And that's kind of the picture I see with income shocks is you have one shock and you never return quite to that health level that you were at before. And then you have another shock. You don't return to that health level you were at before, but then you start seeing this negative relationship between income and health emerge.
Very interesting. Lisa, did you want to say something?
Yeah, it just made me think about the idea. I'm going to pick up on the liquidity constraints comment. And then when that collides, when there's something bad that happens, right? And so that's a very tricky way to think about targeting, but maybe that's another way to think about this is when can resources be available during that negative income shock, right? To help manage it and avoid the further spiral, get back to a baseline if it's resource-based. There's examples of this in emergency cash assistance through some of our mostly state programs. So it just sparked that memory of thinking about, again, I don't have a solution here. We all do, or maybe the funder who's on this call does. But that'd be another way to think about making me extra, at least relieving the liquidity constraints during crises.
So emergency cash assistance as opposed to unconditional cash assistance. Interesting. I think we have time for one more question, and I'm gonna, this is also a little bit beyond the scope, but somebody asked a question that I actually was thinking about as well, Lisa, when you were talking about cash plus interventions, which is, what evidence or insights do we have about cash plus programs that include psychological or social interventions? And then I guess, putting, in my economist jargon, I would say, do we think these are likely complements or substitutes for the cash? And do we have any evidence on that?
That's a good question. Actually, I don't know off the top of my head. I'm thinking this is a good idea to look at what literature has been done, what's been tested. I'm just vaguely familiar of some work in early childhood, which is very much about, in a global context, early education, along with something like social protection, cash transfer. Those have generally found to more parenting, direct parenting interventions. And I think if my memory is correct, the conclusion there is the parenting plus cash has a bigger impact than just parenting intervention or just the cash intervention. But I look to my other colleagues if you're aware of other combo tests.
I asked the question because I was not. But it's a variant of, maybe we need, maybe cash would be more effective in crises. Maybe cash would be more effective when paired with other things. I believe we are almost out of time, so I should probably wrap up. I wanted to, first of all, thank all of our panelists for both sharing, for the amazing work that they have done and are doing, for taking the time to share it with us. The audience, thank you so much for all your great questions. I feel very badly that we didn't get, there were many, many terrific questions and we only scratched the surface. We will certainly share the comments and questions with all the panelists in case they haven't been able to see them in real time. And some of the questions that you had, I suspect if you dig into their papers, may be there, or I'm sure they're happy also to if you write to them to follow up. And then I think I just wanted to end with a note on some resources and opportunities to stay connected with JPAL. First, we would appreciate it if you could fill out this feedback survey so we can continue improving our events. Our newsletter is also a great place to stay connected and learn more about future events such as this one, new research results, opportunities to conduct randomized experiments. We've talked a lot about the potential funder in the audience, but let me actually make a shout out, perhaps even more importantly, to the potential implementing partner in the audience. If you are a state or local government or a nonprofit trying to figure out how most effectively to use your limited resources, that's often a opportunity to do some experimentation and not only help people directly, but learn in the process how to help people most effectively. So that's something we are always eager to support. And as I said, we have a new cash transfer webpage that showcases the work, particularly on cash transfer space, if you want to learn more about cash transfers beyond this webinar. So please, thank you all for your engagement. I really do encourage people in the audience who want to do research, want to fund research, and perhaps most importantly, want to partner with researchers to reach out to us to see where there are opportunities to learn the most and do the most good. Thank you all very much for your engagement, and I hope to stay connected.